Today I've been asked to talk about new and emerging treatments in dermato. So similar to what Joe did with lupus and talking about the need for diagnosis, I find that to be very acutely true in dermatomyositis. And I want to first review a couple of things. So in dermato, a lot of it is what we call clinical path correlation. And in order to know who to treat and who to evaluate in trials, you have to first figure out who has dermatomyositis, which is not always easy. And so one of the clues is to look at the hands and looking at the Gotrin's either sign, which is erythema over the joints, and that can include elbows and knees. And it also papules, Gotrin's papules, which is elevated erythema, erythematous papules in the similar distribution. Here's a Shaw sign. The violaceous color is very characteristic. Resolving with telangiectasia is also characteristic. And as opposed to lupus, where there's sparing of the nasolabial fold, very often there's involvement of the nasolabial fold. And I mean, every patient doesn't read a textbook, but in general, one has to look at the patient and realize, again, that the biopsies for lupus and dermato look identical. And so you can't rely on the biopsy. Very often, a patient with dermato will have a skin biopsy that's read as cutaneous lupus because that's more prevalent, and you have to look at the patient. So here, again, you can see the common via the neck, again, violaceous color. You can appreciate a lot of dyspigmentation, erythema over the eyes, the heliotrope. And these are all, again, very characteristic changes in these two of dermato as opposed to lupus in this patient. Again, emphasizing the distribution. Also the periungual changes, where you can often see erythema, or in this case, you can see dilated vessels in the proximal nail fold area. There can be hemorrhages, there can be dropout. It can look identical to scleroderma. But these findings would be highly unusual in lupus, and very often we do nail fold capillaroscopy to try to amplify what we're looking at if we can't see it with the naked eye. But these things are very important to look for to differentiate lupus from dermatomyositis. So that brings me to the criteria. Again, who do we call dermato? And we had a lot of problems in dermatology because in the mid-70s, there were these criteria that were published, the Bowen and Peter criteria, and they did not allow for diagnosing patients who had skin-predominant dermatomyositis, namely clinically amyopathic dermatomyositis. If you look here, possible DM meant rash and another criteria. But look at the criteria, they're all muscle criteria. So if you didn't have muscle disease, you didn't have dermatomyositis. That's a huge problem. And it's still a problem today, and I'll show you some data about that. But it's a problem in terms of who are we enrolling in trials. Some of our patients enrolled in lupus trials have dermatomyositis. And it's a problem in terms of understanding what organs to look for, because these patients get ILD, and I'll show you some data with that, which we don't see nearly as to that frequency in lupus. They get more cancer and so on. So it's important to know which disease we're talking about. And when we get to trials, we really have to know who we're talking about. So this again becomes a critical issue. So in the diagnosis of amyopathic DM, you get the typical skin changes at DM. Everything I just showed you is what you see, but there's no muscle weakness for a prolonged period of time, and you can't find anything in the muscle. And very often I find people feel like, oh, this is just the early part of classic dermato. But no, these patients can go untreated and have it for decades and not get muscle disease. And it's much more common than we realize. So these patients have a problem in getting a diagnosis, and they're often misdiagnosed with undifferentiated connective tissue disease, SLE, occasionally mixed connective tissue disease. And it's really a big problem. So why does that happen? Well, besides the fact that the dermato criteria didn't work, the SLE criteria are often positive. If you think about it, these patients often have a malar rash, photosensitivity, they can often have ANAs, they can have oral ulcers, and they can exactly fit lupus criteria, myositis, right, and lupus. So it becomes really a big conundrum for patients. So again, the biopsy is not going to help you here. You can't tell a difference between lupus and dermato. So finally, Ingrid Lundberg actually led an effort, it was a decade-long effort, to redo the criteria for dermatomyositis. And I joined the steering committee well over a decade ago, and my mission was to get amyopathic DM included in the criteria for dermatomyositis. And what you can see here was my initial efforts to try to amplify the needs of our subgroup of patients with skin-predominant disease. And my initial wanting to get these patients included was met with, you're going to mess up our statistics as we develop new criteria, please don't stop and go away. So my going away meant going back and doing a study looking at people who met criteria or who were diagnosed with dermato in derm versus rheum. And what you can see here is that over a 3-year period of time, in rheumatology, they weren't seeing or weren't diagnosing these patients with amyopathic or hypomyopathic DM, but that's what I was seeing. And so there was this huge disconnect, and I began to understand why there was this sentiment that it was not an important part of the disease. It just wasn't being seen. So what about other criteria for dermatomyositis? Well, they didn't fare any better, and the amyopathics could not get diagnosed. I mean, 0%, and there were a lot of different criteria, but none of our patients got captured in there. So in these new criteria, which have now been accepted by ACR EULAR, and I actually applaud this effort, it was a huge undertaking, there are 3 skin variables, which include heliotrope, Gotrins papule, and Gotrins sign. And if you have 2 out of 3 of these, you can actually finally get a diagnosis of dermatomyositis, and that's very exciting, and there's really a lot of, you'll look in the literature, there's a lot of papers that have come out on this. Now, we've gone back and looked at our database of patients with skin-predominant dermato, and what I can tell you, and this is out of an N of 99 in our prospective database, that we would capture probably 73% of our patients as having the probability of having an inflammatory myositis based on these new criteria. That means it's not perfect. We need still more sensitive criteria for skin-predominant disease, and that's an ongoing effort on the part of the Derm Society, and Joe and Tony are involved with these efforts as well. And so we need more sensitive criteria, but it's certainly hugely better. So what about the original diagnosis? So here is to show you that of 232 cases of confirmed DM that have come into our database, then when they were referred in, only 44% of them had that diagnosis. So what were they called? And so it turns out 37% came in as lupus or CLE, almost 30% had undifferentiated connective tissue disease, and often patients will have an RMP, and you can see that for sure in many patients with dermatomyositis, and it's actually on the panels, the myositis panels for myositis-associated antibodies. And some were undiagnosed, and then there was this other category. So this just speaks to the need to really become very sensitive to the fact that these patients are not so rare, and we need to figure out who they are. So that also brings me to triggers, and I just want to mention ultraviolet light, which just like lupus, it plays into how we approach treatment, but the idea that we need sunscreen, sun avoidance, sun clothing, sun avoidance as much as possible. Certain medications are triggers. I will mention herbs. I have a practice of people who love to come in with their long lists of herbs, and I encourage you when you have a patient with dermatomyositis to talk to them, because it's shocking how many of them are actually taking immunostimulatory herbs, and maybe try to get them to stop, and good luck with that. And then I will also mention there's some dietary supplements for the weight loss kinds of powders. And I'm starting to see a series of patients who, within days of starting these supplements, have new onset or flares of very stable dermato. And I think we have to give this some consideration as well. So what are the drugs to worry about? Well, we've long known about hydroxyurea, penicillamine, the statins, but also I've mentioned TNF blockers, and the reason why this is important is many of these patients with dermato have a seronegative inflammatory arthritis, and they are thought to have seronegative RA, put on a TNF blocker, and poof, they have much worse disease than what they've had before, or they have new onset dermato. And so it is important if you have a patient with dermato who happens to be on a TNF blocker to consider maybe taking them off the blocker and maybe not putting them on if they have dermato. This is one of our patients who had a big flare after taking this weight loss or diet weight loss product. Again, I would say that our concern is that when you actually take PBMCs from patients with dermato and add rather low concentrations of this diet powder, you get lots of stimulation of pro-inflammatory cytokines. And I think these are in vitro studies, but again, the temporal association is quite significant in the people that we've seen. So what about treatment? So we, just like in lupus, in addition to the topicals that we've talked about with topical steroids and topical anti-inflammatories, we would also think about antimalarials, but there is some controversy here. And part of it is that a number of patients get drug eruptions to antimalarials, and I do think it's important, for instance, with hydroxychloroquine, if you see a reaction, to not totally abandon, one could consider trying to switch to chloroquine or potentially quinacrine. I will say that reactions can be rather severe, and you will have trouble getting your patients to go on them, but if they are willing to, it could be worthwhile. In addition, in our subgroup of patients, we found about 8% got a skin eruption, but I can tell you the literature has up to 30% of patients who start hydroxychloroquine can get a rash, and it can be rather significant. So it's something you need to warn patients about. Doesn't keep me from using the drug, but it's something, it's cautionary. Now here's TNF inhibition, and again the idea that you can have shortly after starting a TNF blocker that you can have an exacerbation with fever or myalgias, arthralgias, increased muscle enzymes, and a rather severe flare of dermatomyositis. Why would this happen? Well, there's a cytokine shift hypothesis, and the idea is that if you inhibit TNF, it promotes the expression of type 1 interferon by altering the balance between Th1 and Th2 cytokines. Increasing type 1 interference may contribute to the exacerbation of symptoms. And that's some of the thinking around why TNF blockade for this particular subpopulation is not a good idea. So that brings me to therapies. So just like in lupus, you have to kind of take a step back and figure out what is the manifestation that's the most significant for a particular patient. And the therapy is going to be determined by whether there's underlying muscle or pulmonary disease. And if you see, I will tell you that I do screen all my patients for ILD. They get a PFTs and a diffusion capacity, and if they're abnormal, they get a high-resolution CT scan, and then I'm collaborating with our pulmonologists. And I will tell you, we have a very high incidence of ILD in our population, even of clinically amyopathic DM. If they have significant disease, and the kinds of treatments that can be done include steroids with or without mycophenolate, cyclophosphamide, IVIG, and tacrolimus. I don't tend to use that much cyclophosphamide, but if you've ever seen a patient with rapidly progressive ILD, which I'm sure you've had, particularly MDA5, you end up throwing the kitchen sink at these patients, and they often end up on many of these drugs because these patients can very rapidly deteriorate. If there's other patients are more indolent, and you may end up still needing to treat them, for instance, with mycophenolate long-term to keep their disease, their lung disease under control. In terms of muscle disease, this must be obviously treated a little bit differently, not that differently, but often with steroids initially with a much more slow taper than you might do otherwise. I will tell you for skin disease, we sometimes have to use steroids for sure, but usually the idea is how do we get some kind of steroid-sparing agent on board that will allow us to get people off steroids. Immunosuppressives are frequently used for muscle disease as well as skin and lung. IVIG, again, is very effective, but is not going to be permanently remittive. You can't stop it, or else the disease usually comes back, and we'll talk a little bit more about that. And then I'll show you some of the Rituximab data. So this is to show you interstitial lung disease before and after a year of mycophenolate mofetil, and I think you can appreciate in the same patient the amount of improvement we see with a lot less fibrosis and inflammation here relative to here. And so one of the things I think that's surprising to many pulmonologists is how reversible this disease can be, because they tend to lump this together with idiopathic pulmonary fibrosis, which is not so treatable. And so we have to kind of teach our pulmonary colleagues who are not necessarily familiar with autoimmune lung disease that this is potentially reversible. And so I think we end up, and that tends to work out usually fairly well, but again, we need to have very good interdisciplinary relationships. So here I'm showing you how much ILD we saw in patients who either had classic DM, amyopathic, or hypomyopathic. And you can appreciate, I think, that there's a lot of lung disease in the amyopathics and hypomyopathics, and really not different from classics. And so when I first showed this at our Rheum Derm Society meeting, probably over a decade ago, people were like, but we don't screen for lung disease. And it was really not something that was really people were aware of, but it's very prevalent. And so I think it's important to be aware of it and to diagnose it and then to treat it, or to make sure that you're referring the patient to somebody who will treat it if needed. So that brings me to the CDASI, which is a one-page instrument. You end up with an activity score, a damage score, and you're scoring various fields such as erythema scale and so on. And this has been able to be delineated into those who have mild disease versus moderate severe, and also what's a clinically relevant improvement. So you need this in order to begin to do studies, and it was something I quickly realized about 15 years ago when we started working on the CLASI, was if we didn't have outcome measures that were validated, we couldn't even get off a dime in terms of looking at anything. And so this was a study that we published a few years ago, and essentially looking at patients who had dermatomyositis that were responders based on that 5-point change in CDASI activity. And what this shows is that the emotional component of their Skindex actually improves. So the red is at the baseline. At visit 2, those who responded to whatever treatment we gave them at visit 1, if they got better, their quality of life improved. But look what happened in the non-responders. Nothing changed. And so that, to me, is very encouraging, because it means if we can treat the activity portion of the disease, we can actually make these patients, from a standpoint of quality of life, improve. So it also turns out, if you compare patients with dermato to other diseases with an SF36, which is a quality of life instrument that allows comparison between different diseases, we can show that, especially in the emotional realm, that these patients are faring worse than patients who've had recent MI, hypertension, type 2 diabetes. And so this is very significant, and again, it speaks to the huge impact this disease can have on patients' quality of life. And it's, again, very true in such parts of the domain such as vitality, social functioning, role emotional, and mental health. So we were interested in itch, and what you can see here is that there is a difference between dermato and lupus in terms of the amount of itch. And so here there's more itch here in our patients, and this is just looking at a VAS score of 0 to 10 for itch. They tend to be much more itchy than the patients with lupus. And when you do studies, it's very important to look at itch, because if the patients can get improvement in their itch, they tend to be a lot happier. This is one of the symptoms that is really most disabling for patients. They can't sleep and so on. So approach to treatment: sunscreens, topical steroids, intralesionals, pimecrolimus or protopic, and then antimalarials such as hydroxychloroquine. And again, this is the therapeutic ladder for antimalarials that we've talked about. I think it's true that adding quinacrine can help for hydroxychloroquine unresponsive patients, but it's not perfect. And this was data that we gleaned from our prospective database, where we looked at patients followed over time with skin-predominant disease. And you can appreciate that hydroxychloroquine is not as good. I mean, Joe showed data where maybe 50% of patients get better. It's more like 25% in dermato, so it's certainly not as good a drug. And very often, if we add another antimalarial, switch to one, and you can get some additional improvement, but some of these patients were already up-titrating to other medications. Very often they end up on various immunosuppressives. Typically, I would say methotrexate or mycophenolate seem to be most effective in this group. And then a few patients need to go on IVIG because nothing else is touching their skin. And in my experience, much of the time you have to kind of keep them on it. If you try to back off, it often will flare. And so it's not permanently remittive for sure. But this is often sort of the therapeutics that we think about for patients with more skin-predominant disease. And it's not the biggest therapeutic armamentarium that we would like to have. And so I think another controversy is whether to use hydroxychloroquine at all, because of the efficacy that I showed you, as well as the side effects. But I would encourage you to think about using it in patients. I have many patients who will get better, and you don't need to advance to immunosuppressives. And because this is often a long-standing disease, I think that it's worth giving it a try for most patients. So the side effects, I think we all know. I will tell you that it's confusing to know about the eye, how to follow the eye toxicity at this point, and also it's confusing to know how to dose patients. And so I think what's very clear is that if somebody is less than ideal body weight, you want to dose according to their actual body weight. So if somebody's very thin, you're going to use, if we use a less than 6.5 mg per kilo per day of a hydroxychloroquine, you want to stick with that with their actual body weight. But otherwise, you would would use that with their ideal body weight. The new guidelines from ophthalmologists would say 5 mg per kilo per day. There's not agreement on this. It's very confusing in the literature, I would say. In addition, how often do you need to monitor the eyes? So often I would say at baseline or close to baseline. And if you listen to the ophthalmologist, they would say not again for 5 years. And so I think if you feel comfortable knowing when that magical 5 years has passed and then start doing 1-year exams, I think that's fine. I think most people, it does seem to be a dose accrual kind of thing, and it's unlikely to get eye problems with hydroxychloroquine until 5 years, but I have a hard time remembering 5 years. So I tend to send my patients back on a yearly basis, but not more often when they're on hydroxychloroquine. However, chloroquine's a different story. There's much more eye toxicity. They need more monitoring every 4 to 6 months. And I would use a drug for refractory patients, but you need to know that they need more eye monitoring. It's also important to know that they can get a cardiomyopathy that's reversible. And so it's sometimes hard to tell. It's the cardiomyopathy from the drug or from the disease. And so that requires actually, actively engaging our cardiology colleagues in that. You can get a myopathy, and so if there's a disconnect and the myopathy seems to be progressing, we've certainly seen patients where you stop the Antimalarial and the myopathy gets better. You can see other side effects as well. But I think, again, it's just good to know about most of these, and I would say they're not very, very common, except potentially for the rash that we talked about. So we've talked about second-line therapies. I will also add azathioprine is probably less effective than methotrexate and mycophenolate. We've certainly used cyclosporin and tacrolimus, especially for lung or refractory skin. It can be effective, but you've got the other issues of long-term side effects with that. Steroids we use sometimes as a bridge if we need to, and IVIG. So that brings me to talking a little bit about the interferon signature, which we know is increased in dermatomyositis. You can see, along with lupus, that interferon is very important. If you look at which interferon, unlike in lupus where it seems to be more interferon alpha, this one is more interferon beta. And you can appreciate that the interferon beta, the actual transcript level correlates with the interferon score. And so it's both beta and gamma, but not as much of an alpha or kappa score. And so any kind of therapies that are targeting interferons probably need to be targeting more beta and gamma. This is just showing a linear correlation between mix-A staining in dermato skin relative to TIF1 gamma antibody, which is one of the autoantibodies, again, implying that type 1 interferons are important, and interferon beta is a type 1 interferon. So where are we going therapeutically? There's been a little bit of more biomarker data with Cifalimumab. I'll show you some of the Ritux data. I would say we're in early days for almost everything here. There are a lot of ongoing trials, and this is an incredibly exciting time. JAK inhibitors sneaks in everywhere, as Joe alluded to. IVIG, there's actually ongoing sub-Q and infusion trials as well, and I'll talk a little bit about the Lanabasum trial. So this is just to show that the interferon gene signature is neutralized in some patients with Cifalimumab, more actually in the blood than in the muscle, but there is some inhibition of the interferon alpha in patients with dermato. And you can see that the people who got more muscle improvement seem to also get more improvement in terms of neutralization with Cifalimumab. But obviously there are lots of patients who don't get better and still have problems with their muscles. And I will mention that there's lots of issues with outcome measures for dermato when it comes to muscle. The MMT is not a perfect exam, it's a muscle strength test. So Rituximab, obviously we know that autoantibodies are important. We think they're important in polymyositis and dermato. And we know that Rituximab can clear B cells that have anti-CD20, and therefore some of the autoantibodies may be prevented. The cells that are making those autoantibodies are eliminated. And there are reports for efficacy for refractory disease in lungs and muscle, but no great trials. It's not so clear for skin. And there was a randomized placebo-controlled trial that was a heroic trial with 200 patients that was done a few years ago, but it did not meet its primary endpoint, largely because the crossover was only after 2 months and you couldn't separate the two groups. But actually, 83 of the patients met the definition of improvement on Rituximab. There was a retrospective analysis done of this, it's the REM trial, the Rituximab and myositis trial. And what they were able to show was 72 adult dermato patients that were followed over the course of 44 weeks and had a VAS score for skin, which is a little bit challenging because it's such a subjective score. But the VAS score was 3.2 on average for these patients, so not the worst skin disease on a scale of 0 to 10. And you can see that this post-hoc analysis that the score went from 3.2 to 2.46 in the course of the study, and that the frequency of any dermatorash decreased from 89% to 76%. So I think, again, we have more to learn. I'm not convinced this is going to be a huge game changer for skin, but very clearly people are using it for refractory lung or for refractory muscle disease. There's ongoing work with the beta-CEP. It's too early to know. There have been a few case reports. And also with anakinra, again, I think I would encourage the use of validated measures for skin, and we need to know if these drugs are working, but there's a lot of interest in anti-IL-1 alpha. We've also heard about interferon beta, as I just told you about, and also the STING pathway. And I wanted to show you that part of the interferon interferon signaling includes JAK1 and TYK2 that have effects on STAT1, STAT2. And so what you can do is with these JAK inhibitors, you can impact this type 1 interferon pathway. And this was a case report in the New England Journal a few years ago in a patient who happened to have dermato and also had polycythemia vera with a JAK2 mutation. And they got Ruxolitinib, and what they showed is that they got better in terms of treatment and disease. It's not so clear if it was just the P. vera got better and therefore the dermato got better, but this is very intriguing, and there's a lot of interest in JAK inhibition for treatment of dermato, so stay tuned. And that brings me to Lanabasum, which is a non-psychoactive cannabinoid which binds to the CR2 receptor on PDCs and lymphocytes. And it suppresses secretion of TNF-alpha, interferon-alpha, and interferon beta from PBMCs of dermato patients in vitro. And this was an NIH-funded placebo-controlled randomized trial. And actually, I want to say it was the first randomized trial for skin-predominant DM. We enrolled 22 patients at our site, and they got a month of half dose, 2 months of full dose, and then a month off drug. So a very short trial. And as opposed to many of the more systemic disease trials, which have to go on for a long time, like a year to show differences, the skin can be a very nice window into seeing a quicker response. And so they only had 2 months of full drug. And then the primary outcome was the CDASI. You can see there was a statistically significant difference between placebo and treatment, and many of them also improved in terms of other outcomes that were tracked. This is just looking at the mean difference in the CDASI compared to placebo, and you can see that the patients who got active drug did much better. Again, statistically significant at the end of the 16 weeks, before and after. And then here, this is data that actually we're going to be presenting at EULAR this year, and this is showing that as patients are then put back on the drug for a long-term extension, and this is now open label, not blinded, not the same level of evidence that you're getting in a blinded placebo-controlled trial, but many of these patients continue to have improvement in their skin activity as well as in their itch. And so stay tuned. I think this is exciting, and they're going to move on and do a much bigger trial in the near future. I will show you also that in vitro that this drug did actually inhibit, you can see here, and these are increasing concentrations of, it used to be AJA, and now it's called Anabasum. The drug has had 3 different names so far. But here you can see that there is a decrease over time with increasing amounts of drug added in vitro to stimulated peripheral blood mononuclear cells when you have a readout of TNF-alpha as well as interferon-alpha. And we did the same thing with interferon beta, and same thing happens where you get just a lot of inhibition of these pro-inflammatory cytokines in vitro with stimulated PBMCs. So in summary, DM is frequently skin predominant. I hope I've convinced you of that. I don't think we know what percentage of the patients, at least 20% we know from one very small study, but it could be a lot more than that. We need better classification criteria, but we have them now, and it is very important to differentiate from undifferentiated connective tissue disease and SLE. We need to check for systemic disease in ways that are really a little bit beyond the scope of what we're talking about today. And we need to treat based on which organs are involved. And we need steroids for muscle and likely many with lung, and requires a slow taper. Steroid sparing with methotrexate, mycophenolate, azathioprine can be helpful. And skin can be treated with antimalarials, but may need immunosuppressants and IVIG. And we've reviewed a number of new treatments on the horizon, which I think is very exciting.